Hello, my name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, and today I'll be talking to you about the proposed physician fee schedule for 2021. Please note that this talk is taking place on August 11th, 2020, so right now what we have are the proposed physician fee schedule changes, so they will become permanent later in the year. Before we begin our talk today, a few disclaimers. Please know that any information provided in today's talk is not to be regarded as legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. And also know that if I happen to mention a company or show a product, neither I nor CCHP has any relevant financial interest, arrangement, affiliation, or relationship with such a company. CCHP was established in 2009 as a program underneath the Public Health Institute to be a California telehealth policy organization. However, became the federally designated National Telehealth Policy Research Center in 2012 through a grant from HRSA, and we've been serving in that capacity ever since. However, we do work with a variety of other funders and partners on more specific projects related to connected health and telehealth. Some of the projects that we do a 50-state telehealth policy report of all the Medicaid policies, laws, and regulations related to telehealth. We are also the administrator for the National Consortium of Telehealth Research Centers, and we convene a group in California called the Telehealth Policy Coalition. The National Consortium of Telehealth Research Centers are made up of the 14 grantees underneath the same grant program through HRSA. There are 2 national resource centers. CCHP is the one on policy, and there is one on technology based out of Alaska, and 12 regional resource centers that cover specific states. So the 14 resource centers work very collaboratively together, and we're your front line for your telehealth questions. So you have a question about how to get started with a telehealth program, what equipment you should be looking into, or questions regarding policy, please reach out to a telehealth resource center. As I mentioned, that there are regional resource centers that cover specific states, but we do all work very closely together. So you're okay with reaching out to one, we'll make sure you get to the right place. I mentioned our 50-state report. So we do track all the Medicaid policies, laws, and regulations related to telehealth. We update this information twice a year, do 2 major overall updates, one in the spring and one in the fall. And we were actually in the middle of doing our spring update when the COVID-19 pandemic hit. So the information on our website is good through February 2020, at least where this 50-state report is. It does not include the temporary COVID changes, and that is because those are temporary changes that is located on a different section of our website that's clearly labeled as COVID policies. But what you will find here on the 50-state are the actual permanent policies, at least to this point, for the 50 states in their Medicaid program, in their statutes, and in their regulations. So the temporary Medicare telehealth policy changes that were made in response to COVID-19 can be sort of broken out into a couple of areas of, what exactly did they address? And the major ones were geographic and site limitations. So where are the patients located? There is also a list of providers, the type of providers could provide services in Medicare via telehealth and get reimbursed, and the type of services that were covered if you use telehealth. A couple other changes included visit limitations, such as the amount of times that you can use telehealth within a certain period of time, what modality you can use, and things around supervision and licensing. All of these changes were temporary, so there would need to be a permanent change in order to make sure that they would last beyond the public health emergency. And depending on what the change was, or what the particular issue was, it would require either a change administratively, which means CMS would need to make the decision to make that change, or it would require congressional action in order to do that. So the major changes, the one that most people are familiar with and that have the most sort of widest impact on telehealth policy and Medicare, actually really involved, for the most part, changes that would require congressional action. So that is location of the patient, and that was removing the geographic limitation or removing the site limitation, what type of building the patient was in when this telehealth service took place. That's something Congress would need to actually get rid of in order for that change to be made permanent. They've only allowed a CMS sort of temporary powers to remove that during this particular public health emergency. The audio only option, now technically when you read the federal law, it may not require action from Congress, but I think that's what CMS would prefer that to happen. It looks probably a little vague in their eyes, in that, you know, congressional intent wasn't really for them to like have that type of broad definition. But even though like there wasn't anything very specific in federal law that said it had to be live video. So put that in a category, and that at least CMS doesn't feel like they have like control over allowing other types of modalities to be used in order to deliver service and reimburse for it. Allowing the list of eligible Medicare providers to be expanded. Again, that would require congressional action as well, a law change. That's not within CMS's power to do so. Expansion of eligible services to provide telehealth from a list of 115 to 240, which is what they did during the pandemic. So that is actually something that CMS can do without like congressional action. That's within their power, just add more of those services onto that list, saying like, this is fine to like provide via telehealth, we can reimburse for it. So that is something that they would not have to wait for Congress to do. But as you can see, for the most part, their hands are sort of tied on this until Congress takes a more definitive piece of action and allows them at least the authority or allows them some sort of flexibility to make the change. Now, one thing that I do want to go over is that there are two distinct areas of services in CMS's eyes, in Medicare's eyes, when you're talking about using technology to deliver a health service. So there is the telehealth bucket, which is dictated for the most part by what's in federal statute, what I just gone over. And these are services that CMS regards as using technology to replace an in-person service. So like an office consultation, instead of doing it in person, you're doing it via telehealth. And then there's another bucket of services that use technology to deliver them. CMS says there's not that one-to-one sort of replacement. It's not a service that we are delivering in person, but technology is able to like suddenly provide these services. And even though there's not this sort of one-to-one replacement for an in-person service, we believe that we should be covering these because it would be good. It can like improve the health for the enrollees, etc. So they call these technology-enabled or communication-based services, and they don't regard them as telehealth. The benefit of that is that they are not held to those federal restrictions on telehealth, because even though they're using telehealth technology, they're regarded as something else, they're called something else. So they're able to have more flexibility and not have like those federal restrictions on them. They do put other limitations on them, such as, you know, the type of patient who might qualify for receiving those services, that type of thing. But they're not hampered by saying, well, it can't take place in the home because of what it says in federal law, saying it must take place in these areas. So these are the two sort of areas, two sort of places where CMS has a little bit of play with, and what they can like say could be reimbursed if you use technology to provide a service. So the first thing, this is a bit of an overview of what they have proposed in a physician fee schedule. And basically, for the most part, it surrounds the services because that is what they have the most control over, what they can do without congressional action. So really what we're going through for the most part is they're proposing making some of the services that they're allowing now underneath the public health emergency permanent as a service that they can cover if telehealth is used. They're also asking questions or asking feedback on a bunch of different things that they also propose that aren't necessarily related to reimbursement of services, but maybe some of those limitations on how often telehealth could be used, or if it could be used to like facilitate supervision. Asking feedback from like the general public on like, should we keep this permanent? And then they're also making some changes around that other bucket of services, those communication-based technologies, and doing things around there. So a few things to also note is that one of the things that I had mentioned earlier is that expanding the definition of the type of modality that could be used. CMS has indicated that that is probably something that they would want Congress to take action on, that they didn't feel was in their power. Seems like, at least from what they're proposing, within their power to make a change for. They have proposed in removing the exclusion of phone, fax, and email system from the definition of interactive telecommunication system in the regs. So in the regulations related to all this is a definition for interactive telecommunication systems. it has a specific definition. And within that definition currently, it explicitly says, excluding phone, fax, and email systems. They're not saying that they're proposing to reimburse for telephone at this moment. They're just saying like, we thought that was like a little bit redundant to have that exclusion in there, so we're going to remove that. So that could be a little confusing for folks saying like, oh, they're removing it, so they're allowing phone. It's like, technically they're not, because there's other parts of the definition. It says something like interactive audio and video, so that there is still that video component there. It's a bit of cleanup for them. So I just wanted to point that out in case people maybe read that within their proposals and maybe got a little bit confused of what they were trying to get out there. But we'll go into some of these in a little bit more detail. So what follows next are the specific telehealth proposals. So remember, 2 buckets, there's telehealth and then there's communication-based technology. So these are the telehealth proposals. Usually to get on this list of services of like what is eligible to be reimbursed if it's delivered via telehealth underneath the Medicare program, you have 1 or 2 ways. And these are 2 tests that they call category 1 and category 2. If you pass one of them, if you fit the bill for one of them, you get that service will get on the list. So category 1, which is where a lot of services get approved, it's for services that are similar to services already approved. So if you suggest a code to be put on the list and it's very similar to another code that's already on the list, then CMS will like say, yes, and that code can be added to the list of eligible telehealth services. That's usually like how a lot of those different codes get put on the list. Category 2 is a little bit harder. So it's for services that aren't similar to the current list of telehealth services, but they pose a significant benefit for the patient, and whoever's proposing that code be added, they have to provide evidence to show that there's a significant benefit for the patient. What makes this harder is there's like not really clear parameters like, well, what evidence do you need? Do you need like a study where there were 100 patients or where there are 1,000 patients, or do you need a study that was published in like the New England Journal of Medicine? I mean, like it's kind of not clear. It's like how much and what type of evidence you need to provide. So it's a little harder to get a service onto that category 2 sort of approval to get on the list. But most services are going through category 1 and getting approval that way. So they are adding, these are some of the services that are already on the list that was put out by the public health emergency. These were services when COVID hit, they like also added to the eligible list of services. What CMS is saying is like, you know what, these are really similar to category 1, or there was enough evidence where they fall into the category 2 criteria. So we're going to make these permanent. And these are the services that are on here. One thing to note, so home visits, that last bullet point down there, for home visits, they're not saying home visits for everything. It is still limited by what's in federal law, which prior to COVID-19 was a very narrow band of services, and those were end-stage renal disease and treatment for substance use disorder and a co-occurring mental health issue. So that home visit, even though the definition for them is pretty broad, it's only for those types of services. But these are the category 1 services that they're saying, or fall in category 1 or category 2 services that they're saying we are proposing to make it eligible. And I will say, when CMS does do that and they propose it, even though they do take feedback from the general public, for the most part, these services, once they propose them, you know they're going to get on the list. Now, CMS, this is what's different here, they're proposing a category 3, and that these would add services temporarily to the eligible list. So these are services added to the public health emergency list now, but they're saying there's not enough evidence for them to like fall into category 1 or category 2. So we're going to propose this category 3, where we're going to allow them to be on the list, but temporarily, so we can see if there's enough there where they can qualify then to come underneath category 1 or category 2, and they'll be eligible through the calendar year of when the public health emergency ends. Now, this is something that CMS can do. So when CMS is adding services to the list, they do have the power to determine sort of like what test it can be used in order to add those services to the list. So they were totally within their power to do this with category 3, but it's a little bit unusual because it is a new category and they're saying it's only temporary. This is kind of like they're saying there's just not enough evidence for us to decide if this is like good to still have on the list permanently. So we're giving it a little bit more time for it. So, and those are the ones that they are suggesting. And then there's like a bunch of other things that they were requesting comments for. And some of these things were what we saw happened, the temporary changes that they made in reaction to COVID. So other codes that were not on the previous slide saying like, what of those codes that we added during the public health emergency should we consider to be permanent ones? You know, send us in your comments on that. The direct supervision through live video, again, they're recommending maybe through the end of the calendar year of when the public health emergency is declared over, asking like, should we keep this around? Allowances made for live video for teaching physicians, revising the frequency limit and the use of telehealth and SNFs, allowing periodic assessment for OEDs and OTPs to be via live videos if certain requirements are met, continuing to allow telehealth be used to meet requirements of physician, non-physician to personally perform required visits in nursing home. And also, should CMS include exceptions to electronic prescribing for controlled substances? What other services that fall outside the limitation of federal law that can be included on the telehealth services? So these are a lot of the waiver changes that they made within the Medicare program that maybe didn't really directly relate to reimbursement, such as like the supervision changes, some of the frequency limits, and saying, should we keep this around? Public, we want your comment and thought on this, or, you know, should we just let them lapse when the public health emergency is declared over? So the virtual technology communication-based proposals, they also made proposals for these sort of like non-telehealth services that do use telehealth technologies, but they don't label them as telehealth. By the way, and when COVID-19 hit, they made some changes, some of the online evaluations they added new codes for, but for the most part, these virtual communications, technology-based services, they didn't have to make a lot of adjustments for in reaction to COVID, but they are suggesting some changes now. So they're proposing adding new codes. Right now, they're labeled as G20XO and G20X2. These are for clinical social workers, clinical psychologists, physical therapists, OTs, and speech language pathologists who can provide a brief online assessment and management services, virtual check-ins, or remote evaluation, allowing them to bill some of these services. So before COVID hit, PTs and OTs were very limited, if at all, of what they can use technologies for to provide services and get reimbursed for Medicare. So they're opening it up at least to these other healthcare professionals, at least to use the virtual codes or the technology-based codes. Remote patient monitoring, again, a lot of specific adjustments to remote patient monitoring, which, you know, for the virtual and communication-based technology-enabled services falls into different categories. They're not necessarily called remote patient monitoring. They may be called chronic care management or primary care management services, but basically, you know, allowing certain flexibilities that they were allowed during the pandemic to carry over. So after the public health emergency, an established patient-physician relationship will be required for the remote patient monitoring services to happen. The CMS is proposing to make the ability to obtain consent at the RPM services are furnished permanent. So that was something that they allowed to help facilitate use of remote patient monitors, to get that consent at the same time, as opposed to like before you can start the services, you need to get consent. Allowing auxiliary personnel to furnish certain services under physician supervision. After the public health emergency, requiring for at least 16 days of data collection with each 30-day periods for certain codes. Only physicians and practitioners eligible to furnish E&M services may bill for RPM services. And it's acute as well as chronic conditions can qualify for a remote patient monitoring code. And then the definition of interactive communication in certain CPT codes is specified that it is real time and includes synchronous two-way interaction that can be enhanced with video or other types of data. So just very specific changes that they are proposing as well. Other virtual communications-based proposals are proposing to allow additional codes to be built concurrently with traditional care management. They're also proposing to allow FQHCs and RHCs to bill for principal care management starting in January 2021. And then they're seeking comments whether CMS should develop an alternative coding and payment for services similar to virtual check-in, but would be longer and of higher value. And one of the benefits of that is those virtual check-in codes, you can use the phone, audio-only phone. So while they may not have been able or felt like they were able to continue to allow some of those telehealth codes to be delivered via audio-only phone, they're trying to expand it in like the communication-based bucket or those virtual communication codes. But they're also noting that for those virtual communication codes, currently those are quick check-ins. So they're like 5 or 10 minutes and providers only get paid like $10 to $15. So they're now suggesting, should we look at this as a way of providing services, but let it be longer and the provider can get paid more. So they want comments back on that. So you'll notice like a lot of these proposals, they were specific saying, we want public, we want your feedback on how did this go? Should we keep it around? What are your ideas and your thoughts on that? So a couple of things. As I noted, major changes would need to be made by Congress. So that's like removing the geographical limitation, allowing more providers to provide services via telehealth, such as keeping like the FQHC and RHC allowance permanent. That would require congressional action, and allowing home to be an eligible originating site for other services aside from end-stage renal disease and opioid use disorder treatment and co-occurring mental health disorder. Note though, everything that I went over are only proposed. They're not permanent right now, because what they do is they publish this and then they have to give 60 days for public feedback. So this is your chance. You think they missed something to like, send that in saying, I think you missed this, you should add this code here. Keep in mind though, you can send them a letter saying like, I think you should remove the rule restriction, but that's not within CMS's powers to do. So when you do your comments, you might want to just stick to what they can actually do, because then you'll just get a response back from CMS saying like, we can't do it, we got to wait for Congress. And then comments are due by October 5th, 2020 at 5 p.m. I don't think in the Federal Register where this was published, it mentioned Eastern time, but I'm putting Eastern time on the slide here because they are located on the East Coast. So I'm assuming they mean 5 o'clock their time. So just keep that in mind if you are hoping to submit comments, but want to try to get them in as early as possible. But if you are doing it on October 5th and you're in a different time zone from the Eastern time zone, keep that in mind that they have a specific time deadline as well. And then just a couple of links to some of the CCHP resources, and that is it. And thank you for listening. Please keep in mind this was filmed on August 11th, 2020. So if you are watching this video at a later date, it may no longer apply. So, but if you're watching it during August of 2020 and September 2020, this is some information that you may find useful. So thank you for listening, and I hope to see you on another video. Thank you.